The broadcast is now starting. All attendees are in listen-only mode.
The floor is all yours.
Okay, thank you very much. Good evening. I'm Dr. Preeti Puntambekar. The topic for today's webinar is Advances in Medical Treatment of Epilepsy. Before we talk about advances, it is appropriate to take a look at the history of epilepsy. The Greek physician Hippocrates was the first to establish the idea that epilepsy is not a curse and is a real medical condition. Through the ages, several others have contributed to the history of epilepsy. Today we know that epilepsy is defined as 2 or more unprovoked seizures. A seizure is caused due to sudden excess electrical activity in the brain. A single seizure can occur in about 5 to 10% of the population. However, epilepsy or recurrent seizures occurs in 0.5 to 2% of the population. The image here shows a neuronal synapse where 2 neurons come together and they communicate via these neurotransmitters, which then act on receptors or ion channels across the synapse. Most of our anti-epileptic medications target these neurotransmitter molecules, ion channels, or receptors. Mankind has been looking for treatment for epilepsy for a long time. So the first medication that was tried was bromides as treatment for hysterical or catamenial seizures in young women in the year 1857 by Charles Lecocq. Subsequently came phenobarbital in 1912, phenytoin in 1937, ethosuximide in 1950, carbamazepine in 1968, and valproate in 1974. So these were the so-called first-generation anti-epileptic medications: phenobarbital, phenytoin, primidone, ethosuximide, carbamazepine, valproate, and the benzodiazepines diazepam and midazolam. And this is everything that we had in 1988. It fit very well on one page. Then I would call these as the second generation anti-epileptic medications: felbamate, gabapentin, lamotrigine, topiramate, tiagabine, levetiracetam, oxcarbazepine, zonisamide, and pregabalin. So what do we expect from newer and newer anti-epileptic medications that come out? I think we want them to be more effective for seizure control. We want them to have less side effects, to have less interactions with other medications, to have easy dosing and monitoring. And of course, we want them to be cost effective. So this is the ideal case scenario or ideal medication. And I have listed some of our newer anti-epileptic medications that have come out on this slide. Let's see how they hold up compared to our expectations. So the topiramate extended release Quidexia XR came out in 2014. S-like carbazepine came out in 2013. Trokendi XR in 2013. The Oxtella XR, which is the oxcarbazepine extended release, in 2012. Perampanel Fycompa in 2012. There were 2 medications in 2011. Clobazam on-fee was marketed in the United States, and ezogabine or Potiga. Prior to that, we have vigabatrin, Sabril, rufinamide, Banzel, and lacosamide or Vimpat. So I will be going through each of these in more detail. in the next few slides. But before that, I want to talk about some basic pharmacological aspects of these medications. This is important in understanding and selecting the right anti-epileptic medication. So you have this box which says pharmacodynamics. What that simply means is what the drug does to the body. It tells us about the mechanism of action of the drug, how the drug acts on the ion channels or receptors that we talked about. And the major inhibitory neurotransmitter in the brain is GABA, and the major excitatory neurotransmitter in the brain is glutamate. So anti-epileptic medications essentially increase the inhibition or suppress the excitation by their mechanism of action. So why is this important? Knowing this is important for your doctor to choose the correct medication depending on the type of epilepsy that you have and the epilepsy syndrome that you have, maybe whether seizures come from a focal area of the brain or the seizures come from all of the brain all at once. Another important pharmacological concept is the pharmacokinetics. This simply means what the body does to the drug. It includes the absorption of the drug, the distribution of the drug in the body, metabolism of the drug, and elimination. Why is this important? This is important in dosing the anti-epileptic medication and in monitoring the drug as time goes on. So the third important aspect to know is the efficacy. So this is based on clinical trials data. So most of our drugs are compared to placebo in the clinical trials, and the measure that is used commonly is the median % reduction in seizure frequency. And lastly, we have the side effect profile. This is just important to know whether the medication is suitable for a particular patient profile with their unique age and other medical conditions. So piecing all this information together should give you some idea about each drug that we talk about. Another concept that I want to talk about is that of extended release medications. Are these better? What they do is they reduce the fluctuations in the drug plasma concentration. And for certain medications, this may prevent adverse events caused by peak dose toxicity and breakthrough seizures that occur at trough concentrations. The same is explained by this graph. This is a simple drug concentration on the y-axis versus time on the x-axis. And the dotted line shows the intermediate release drug, which is dosed 3 times a day. And the dark thick line shows the extended release drug, which is dosed once a day. So let's go back to that slide. So if you see that the intermediate release medication, or the dotted line, peaks, and as the drug peaks, you can have side effects, and as the drug drops at the trough, you can have breakthrough seizures. The extended release version eliminates this and make sure that the drug is in the therapeutic zone of seizure control. So with that in mind, let's go to the first medication. Extended release oxcarbazepine came out in 2012. It's indicated for adjunct treatment of partial onset seizures in adults and children 6 to 17 years of age. Mechanism, it inhibits voltage-gated sodium channels and thereby stabilizes excitatory neuronal cells. It's a modified release formulation, and oxcarbazepine is an ideal drug for an extended release version. The trial data showed that the median % reduction in seizure frequency was about 38.2% for the 1200 milligram, 42.9% for the 2400 milligram compared to the placebo. The placebo number here, 28.7, is slightly high. However, in the post-hoc analysis that they did after the trial, both of the doses of the medication were significantly superior in the North American cluster. These are the numbers given below, which show that both doses are effective. Oxtellar XR is absorbed better on empty stomach. The time to peak of the major metabolite is 7 hours. You need a higher dose of this medication compared to oxcarbazepine. So those medications are not bioequivalent in terms of milligrams. Protein binding is 40%, liver metabolism, the elimination half-life is given here. The side effect profile is very similar to oxcarbazepine with no surprises there. Dizziness, vomiting, headache, somnolence, diplopia, asthenia, balance disorder, and fatigue. So that's the extended release oxcarbazepine. Now the next one is eslicarbazepine. This came out in 2013, also indicated for adjunctive treatment of partial onset seizures. Mechanism is inhibition of voltage-gated sodium channels. This is a third generation carbamazepine or Tegretol, which is an old medication. So it is a prodrug which then gets converted to S-licarbazepine, which is the active metabolite, which is responsible for the therapeutic effect of the drug. And it avoids the R-licarbazepine. This is thought to be responsible for the side effects of the medication, which are avoided. Medication is not affected by food. The time to peak is 1 to 4 hours. Plasma protein binding is less than 40%, and the half-life is 13 to 20 hours. Drug interaction, in addition to the common drug interactions that occur among antiepileptic drugs, such as hepatic induction, this medication may also increase serum levels of phenytoin. It may also decrease some of the thyroid function tests. The efficacy was based on 3 clinical trials. The median % reduction in seizure frequency was about 30 to 40% at doses 800 milligram and 1200 milligram compared to placebo. Other studies also show that once daily dosing resulted in similar plasma exposure compared to twice daily dosing, so it can be given once a day. In terms of side effects, common side effects are dizziness, somnolence, nausea, headache, diplopia, vomiting, vertigo, ataxia, blurred vision, and tremor that have been reported. There was a low incidence of hyponatremia reported, and there was no increase in the cholesterol and glucose with less hepatic induction and no weight gain. So these were all advantages over the parent drug, carbamazepine. In addition, the once daily administration allows for smoother release and less peak dose side effects. So then there is the extended release topiramate. This has a broader spectrum of action similar to topiramate. It's indicated for partial onset seizures. It's indicated for generalized tonic-clonic seizures, monotherapy, and adjunct treatment, and also for Lennox-Gastaut syndrome. So Lennox-Gastaut syndrome is a type of refractory epilepsy with different types of seizures such as tonic seizures, atonic seizures, myoclonic seizures, and generalized seizures. There's developmental delay, and there are specific EEG patterns that are seen. So topiramate has a broad mechanism of action. It inhibits voltage-dependent sodium channels. It also augments the inhibitory GABA system in the brain. It antagonizes the AMPA, or the excitatory glutamate receptors, and also inhibits carbonic anhydrase enzyme. Time to peak plasma is about 24 hours. It is bioequivalent to topiramate at steady state. That means you can give the same milligram dose of both and is equivalent. Plasma protein binding is 15 to 41%. Elimination half-life is 31 hours. It's not extensively metabolized. It's primarily eliminated, unchanged in the urine. It has some drug interactions. You should have, as with topiramate, use caution when on metformin because of metabolic acidosis. The studies show that once daily extended release topiramate, it caused fluctuations of plasma concentrations of about 26% and 42% compared to 40% and 51% for the the older medication topiramate. So slight improvement in less fluctuation. Efficacy is based on the topiramate trials. Median percent reduction in seizure frequency was from 30 to 45%. Side effects reported in the study were somnolence, dizziness, paresthesia, weight loss, fatigue, and of course cognitive neurological functioning. It can cause dysarthria, aphasia, and some memory impairment. So in addition, we all know that topiramate can also cause elevation of ammonia, renal stones, metabolic acidosis, glaucoma, etc. And so there are two extended release medications, Trokendi XR, which is the capsules, and the Quidexi XR, which are sprinkles for patients who experience challenges swallowing whole capsules. So now we have looked at the left-hand column, which are modifications of existing medication. Let's start with the other medications on the right. Perampanel came out in 2012. It was indicated for adjunctive treatment of partial onset seizures with or without secondary generalized seizures in age group 12 years and older. The mechanism is, it's a highly selective, non-competitive AMPA-type glutamate receptor antagonist. So it has a novel mechanism of action against the excitatory glutamate receptor. It can be given in a single daily dose. The plasma protein binding is 95%. So it is highly plasma protein bound. So I talk about this plasma protein binding because this is important in the patient who has a low protein or low albumin state, who may have variable levels of this medication. Also, if a patient is on another medication which is also highly plasma protein bound, then one medication can displace the other from protein binding and result in fluctuation of levels. Metabolism is mostly hepatic. The half-life is 105 hours. So it's a very long half-life. What that means is that once it takes a long time to achieve a steady state level. And also if you have a side effect, and then it could take some time for the medication to be out of your body. Since it is metabolized through the liver, it has interactions with other drugs, and one may need higher doses if you take a hepatic enzyme-inducing drug. So the efficacy was based on 3 studies which showed the median percent reduction in seizure frequency from placebo was at best 19 to 33% for doses 2 to 12 milligram per day. Side effects of perampanel reported were dizziness, somnolence, fatigue, nausea, headache, some weight gain. There was some false ataxia reported. There was rare aggression, homicidal ideation, reported irritability, anger, hostility, for which it received a black box warning, but these side effects were rare. So that's perampanel. Then there is clobazam, which came out in 2011. Was indicated for adjunctive treatment of seizures associated with the Lennox-Gastaut syndrome in patients 2 years and older. It's also proving to be a useful medication for refractory partial seizures. Mechanism is it's a benzodiazepine. It potentiates GABAergic system by activation of the benzodiazepine site on the GABA-A receptor. The time to peak for the medication was 0.5 to 4 hours. It's 80 to 90% plasma protein bound. It's converted to metabolite in desmethylclobazam. This has about 1/5 the activity of clobazam. And it's metabolized in liver. The half-life is also pretty long. The efficacy was mostly for over 5 years. They studied the Lennox-Gastaut syndrome patients and saw that most patients achieved a 75% reduction in their drop seizures or atonic seizures, and at least a 75% or more reduction in their total seizures. Side effect profile, it can make you sleepy, somnolence, lethargy, ataxia, double vision. Some aggression was reported, irritability, fatigue, pyrexia, nausea, vomiting, constipation, and of course, if you abruptly discontinue the medication, since it's a benzodiazepine, you can have withdrawal symptoms. Another medication came out in 2011. This was the ezogabine, Potiga. It's indicated as adjunctive treatment of partial onset seizures in 18 years and older patients. The mechanism is selective activation of the KCNQ potassium channel, resulting in stabilization of hyperexcitable neuronal cells. So this medication also has a very novel mechanism of action, different from other medications. So it was exciting when it first came out. Time to peak was 0.5 to 2 hours. Plasma protein binding was 45 to 80%. It's metabolized by the liver. Half-life is 7 to 11 hours. It may have some drug interactions with digoxin. The efficacy, median % reduction in seizure frequency during the studies was shown to be 31% for 600 milligram, 39% for 900 milligram, and 44% for 1200 milligram, which was very good. In the initial studies, the side effects were dizziness, unsteadiness. There was a rare side effect of urinary bladder retention because these receptors are present in the urinary bladder, and it caused the bladder to relax. Some patients even needed catheterization. It had some neuropsychiatric side effects, confusional state, psychosis, hallucinations, and it prolonged the QT interval. This is on the EKG, or the cardiac monitor. However, later on in 2013, FDA issued a black box warning for blue discoloration and the pigment deposition in the retina of the eye and also in the skin and fingernails. So there was a concern for potential visual loss. Some of these patients had no prior visual testing and their visual acuity was not perfect. It's unclear whether it causes reversible or irreversible vision loss, but it was a concerning side effect. The recommendation now is that eye examinations, including visual acuity and dilated fundus examination, should be done before starting the medication and for every 6 months during treatment. So that's the story with ezogabine, in which some side effects manifested much later after the drug came out on the market. Vigabatrin came out in about 2009. It was indicated for adjunctive treatment of partial seizures ages 10 years and older, and for monotherapy for infantile spasm 1 month to 2 years of age. So infantile spasms is a type of epilepsy occurring at early age, 4 to 6 months of age, with spasms and developmental regression and some specific patterns seen on the EEG. The mechanism of this drug is also novel. It is an irreversible inhibitor of GABA transaminase. This is the enzyme which metabolizes the GABA. So this resulted in increasing levels of the inhibitory GABA, which was protective against seizures. The time to peak is 1 to 2.5 hours. It has no plasma protein binding, mainly eliminated through the kidneys. Renally impaired patients will need some dose adjustments. The half-life is 5 to 10 hours. It has some drug interactions with phenytoin, and it may increase side effects of clonazepam. Its effectiveness was shown in studies in which half of the patients receiving 3 grams and 6 grams per day of vigabatrin achieved more than 50% reduction in their seizure frequency. And for the infantile spasm group, it was also very effective. Rapid spasm cessation and maintained spasm freedom in about 70% of the infants. Side effects were again concerning. It does cause progressive and permanent bilateral concentric visual field constriction and decreased visual acuity. So it may result in, what that means is it may result in a decrease in your peripheral vision, not the vision in front of you, but in your side vision, for which it received a black box warning. So this risk for this side effect increases with total dose and duration of treatment, and periodic vision assessment is recommended at baseline and every 3 months during therapy. It's also recommended every 3 to 6 months after discontinuing therapy, because this side effect can happen later as well. Other common side effects are somnolence, fatigue, nystagmus, memory impairment, some abnormal coordination, anemia, weight gain, and peripheral neuropathy. So vigabatrin, again, came out in 2009. Prior to that, we have rufinamide in 2008. Indicated for adjunctive treatment of seizures associated with the Lennox-Gastaut syndrome ages 4 years and older, and adults with Lennox-Gastaut syndrome. Also can be useful in refractory partial seizures. The mechanism of action was modulation of sodium channels, slowing the recovery and making sure that they are in a prolonged inactivated state. The peak plasma was 4 to 6 hours, plasma protein binding was 34%, it was hepatically metabolized, and a half-life was 6 to 10 hours. So it does have some drug interactions. The clearance was decreased by valproate. So if a patient is on both rufinamide and valproate, they may have elevated levels of benzyl, and so they may need a lower dose. Also decreases effectiveness of oral contraceptive pills, like many of the other medications as well. The efficacy was for partial seizures, the percent reduction was 20.4% for the Lennox-Gastaut group. It was 32.7% decrease in seizure frequency. For the drop attacks, it was 42.5%, so it's an effective medication. Side effect profile: dizziness, fatigue, somnolence, nausea, coordination abnormalities, some gait disturbance, ataxia. There's a caution in people with familial short QT syndrome. This is a finding on the EKG, so an EKG is needed prior to starting the medication, and some hypersensitivity syndrome that was reported as well. So that's rafinamide for you. And then coming to another medication, lacosamide, in 2008. It's indicated for adjunctive treatment of partial onset seizures in adults ages 17 years and older. However, this has a new indication now in 2014. It's also approved for monotherapy for partial onset seizures. Mechanism of action is enhancement of slow inactivation of voltage-gated sodium channels, making sure that they are inactivated and cause protection against seizures. Time to peak was 1 to 4 hours. It is less than 15% plasma protein bound. There's some hepatic metabolism, but primary renal excretion, elimination half-life was 13 hours. The efficacy median percentage reduction in seizure frequency was about 30 to 40%. The numbers are given below for 200 milligrams, 400 milligrams, and 600 milligrams that were tried. Side effect profile, it does cause dizziness in some people, ataxia, diplopia, headaches. It did cause a dose-dependent increase in the PR interval. This is again on the EKG or the heart monitor strip. And so it's there is caution for its use in people with a heart block or a AV block of marked first degree, second degree, also another heart conduction problem called sick sinus syndrome. Patients may be on other medications that also increase the PR interval, and then you should be cautious with this medication. Also in severe cardiac disease such as myocardial ischemia. Some reports have shown syncope and atrial fibrillation and flutter. However, most of these are like dose-dependent and easily managed if they arise with lowering the dose of the medication. Some may need transition to another medication, of course. It also contains aspartame, and that's just a caution for people who have phenylketonuria. So that's Vimpat, came out in 2008. And so what should we look forward to in the very near future after these medications that we talked about? So there's intranasal midazolam, which is very exciting. It is an rescue medication with a rapid onset of action. It's shown to be highly effective, easily crosses the nasal mucosa, and causes good levels in the plasma and in the brain. So this is a benzodiazepine, of course, acting on the GABAergic system. So it's an ideal medication for refractory seizure patient population. You can use it at home for termination of seizure clusters in pediatric patients especially. So this is an exciting new development to look forward to. Another medication is ganaxolone. This is a neuroactive steroid. It's a synthetic analog of an endogenous hormone, actually, allopregnanolone, which is from the progesterone, which is a hormone in the body. So it acts by modulation of the GABA-A receptor, and it's also a different novel mechanism and novel medication being a neuroactive steroid. So that's something to look forward to. Then there's brivaracetam, which is similar to levetiracetam, which we all know. Mechanism of action is the same, novel high-affinity synaptic vesicle protein 2A ligand. Now what that actually does and how it causes seizure prevention is not known, but the mechanism is similar to levetiracetam. Some other mechanisms are also proposed involving sodium channels for brivaracetam. It's also more, it has a more than 30-fold affinity for this SV2A, so it could be a more potent medication. So you might see this medication soon on the market. And of course, any discussion would be incomplete without cannabis. And this is, I want to mention that this is the topic of a separate webinar. And I just want to mention that the two main constituents are tetrahydrocannabinol, which is the primary psychoactive constituent, and cannabidiol, CBD, which is the primary non-psychoactive constituent. So how do they act? The proposed mechanism of action for the THC is it acts through the endocannabinoid system. These are the cannabinoid receptor 1 or CB1 receptors in the brain. They are G protein coupled receptors which cause slow modulation of neuronal pathways and then inhibit synaptic transmission through the ion channels. So THC acts through this way. For the CBD, multiple actions are proposed. It is thought to act through the serotonergic pathways, through the excitatory NMDA receptors, regulates the calcium flow in the neurons. It also supposed to enhance the adenosine signaling, adenosine which is a new target for anti-epileptic medications. And it also increases inhibition through the GABA-A receptors. So very exciting, but studies will show in the future the results from medical marijuana. Here are some resources available to look into for upcoming anti-epileptic medications and clinical trials. So just to briefly summarize what we talked about, the currently available medications. We talked about oxcarbazepine extended release. This is a good medication. It's better tolerated than oxcarbazepine. So if you have side effects to oxcarbazepine, but you find it effective for seizure control, it's a good medication to switch to. Then you have S-like-carbazepine, which is advantageous over carbamazepine in terms of no hepatic induction, less hyponatremia, also less effect on cholesterol glucose and weight gain. Then there is topiramate extended release, which is mostly similar to topiramate, may have smoother release and now available as sprinkles as well. The perampanel of Fycompa has a very novel mechanism of action on the AMPA receptors. It's indicated for refractory partial seizures. It can be given in once daily dosing. It does have high protein binding and a rare side effect of aggression. Clobazam on-fee is indicated for Lennox-Gastaut syndrome, also commonly used for refractory partial seizures. Side effects, of course, somnolence and withdrawal symptoms on discontinuation abruptly. Then we saw the ezogabine or Potiga having a novel mechanism on the potassium channels. And it's indicated for refractory partial seizures, the concerning side effect being the blue discoloration of the skin and pigment deposition in the retina. We looked at vigabatrin, Sabril, which indicated primarily for infantile spasms, may be used for refractory partial seizures, but the concerning side effect is the loss of peripheral vision, which needs to be monitored. Rufinamide is indicated primarily for Lennox-Gastaut syndrome, also can be used in refractory partial seizures, has some side effects and interactions and needs monitoring. Lacosamide is indicated for partial seizures, both adjunct therapy and monotherapy, and has no significant drug interactions, has some cardiac side effects which are really dose dependent, does not require any drug level monitoring, and has no cognitive side effects. So these are the medications that I talked about. And just to conclude now, we have newer anti-epileptic medications which offer us novel pharmacokinetics with easy dosing monitoring, improved tolerability, less adverse effects. These newer medications offer novel mechanism of action and probable improved efficacy and less drug interactions because of that. So the anti-epileptic medication choice and rational polytherapy should be made by you and your epileptologist based on your epilepsy type, whether you have partial or generalized seizures, your age, gender, your medical history, the pharmacology of the anti-epileptic medication, including the side effect profile, and of course, cost of the medication. So to conclude, this is what I wanted to talk about today about the topic of advances in medical treatment of epilepsy. Of course, certain patients may not be well controlled with medications and may need other treatments such as diets and epilepsy surgery and devices. However, just in terms of medical treatment, we have come a long way from the first medication in 1857 that was tried. And I think we have an even brighter future with new medications that will be coming. So thank you very much for listening today. If there are any questions, please email and I'll be happy to answer them. Thank you.